apologize. We've got a potential quarantine situation with somebody, and then we've got a couple other members that I think are on their way. But so that we don't delay things further, Mr. Snyder, would you come up and give us your presentation for Medicaid? Thank you for being here. Is your light on your microphone? Test it one time, make sure, because we're live streaming and I don't think they can pick you up unless you're. Is the green light on? Just push the button right there on the top.
There we go.
Where it says push?
Yeah. Yeah, I'm my tech savviness ended with Microsoft Excel. So, look, good morning. It's a pleasure to be here to discuss the Division of Medicaid's budget, and any discussion about the Medicaid budget is really a discussion about the state budget. This is going to be my fourth legislative session to present to members of an Appropriation Committee, and when I spoke to you about 5 days into the job, I talked about some expectations for the Medicaid program. And at that time, Medicaid was running annual state budget deficits, and there was a perception that Medicaid spending was unchecked and crowding out priorities like schools, roads, and public safety. Today, state fiscal year 21 direct state support expenditures are on track to be the lowest direct state support spend in a decade, even as enrollment surges close to its 2015 peak. The Schedule 1A in the legislative bulletin has agency-specific state support appropriation data. I looked at that, and the Division of Medicaid comprised about 15.5% of direct state support appropriation in state fiscal year 2017. 4 years later, Medicaid's share is 12.7%. I will briefly touch on state fiscal year 2021 and then move to state fiscal year 2022. For state fiscal year 2021, the agency will have sufficient direct state support funding. We also have no plans to use the $85 million in capital expense funds that were appropriated as part of the $898 million state support appropriation. We want to avoid using one-time money on recurring expenses, and without the capital expense funds, this year the direct state support spend drops about 9.5%. But because of the public health emergency and the increased federal matching funds attached to that public health emergency have lasted longer than originally anticipated, the Division of Medicaid will need either one, escalation authority, or two, additional spending authority in federal funds. In a letter I sent to Appropriations leadership late last week, I made a request for a 3.6% increase in federal spending authority for state fiscal year 2021. That's about $199 million in special source funds. State fiscal year 2021 will be the third consecutive year without a state funding deficit. That's a basic accomplishment for nearly every other state agency, but it may be unprecedented for Medicaid this century. Last January, I came to you with a pretty optimistic picture for overall spending, but a large year-over-year direct state support funding request. Today I come to you with a more guarded long-term forecast for total Medicaid spending, but no state support funding increase. For 2022, we continue to request a small decrease from the state fiscal year 2021 number. The Medicaid budget is notoriously difficult to predict, and it's even more unpredictable today. In the handout, you'll see some cost drivers and some things that I think could be variables on what we will see, in spending in the state fiscal year 2022. I think the biggest question mark is enrollment growth. Total Medicaid and CHIP enrollment has risen 10.5% since March. An additional 70,000 Mississippians have health coverage without the need for more state money. Part of that growth is economy related. The non-disabled, non-pregnant adults whom we categorize as called low-income parent caretakers. That category of eligibility has increased by about 20%. But most of the increases are due to the continuous eligibility requirement that Congress attached as a condition of the 6.2 percentage point enhanced federal funding. The number of pregnant women has more than doubled, and that increase isn't because of more births, but because they're continuing to get coverage past the traditional 60-day postpartum coverage cutoff. We're also seeing a large increase in the number of healthy children in the program. What would happen in the past is a phenomenon we call churn. Some families would let their child's enrollment lapse after 12 months of coverage. The child was healthy, and due to federal rules on retroactive eligibility, and we're sick, they could go to the doctor and get retroactively enrolled, and the provider could get paid. With continuous eligibility, we're not seeing as much of that. But I think the biggest thing to point out about enrollment is that when the public health emergency ends, it's going to take a while for the enrollment to return to pre-COVID levels or close to pre-COVID levels. And I think it's going to probably take 12 to 15 months to get that enrollment down, and even then it's going to be, I think, higher than pre-COVID levels. Another potential uncertainty is the timing on the enhanced FMAP. It's difficult to do good forecasting when you don't really know what the federal match rate is going to be for a given quarter, and enrollment numbers continue to shift. Some of the leadership in the National Association of Medicaid Directors has been working with Congress and the presidential transition team to recommend some certainty around the enhanced FMAP, and I believe as appropriators, you need to have some more certainty than you do today. Vaccine administration costs are another X factor for state fiscal year 2022, though maybe not a large one. Vaccine administration costs are a combined $45 per person for both doses. Now, a lot of the Medicaid population, the nearly 400,000 children in the program, aren't going to be, administered the Moderna and Pfizer vaccines. And Medicare should pick up most of the cost of the vaccine for the 160,000 dual eligibles in the program. The question is when will there be a vaccine, ready for children, and also when will there be a one-dose vaccine, ready, which may lower some program, costs or some of the original expectations for the vaccinations. Changes in the Medicaid tech bill are likely to add recurring costs to the program. The elimination of the 5% assessment on services is expected to cost $45 million total in year one and over $10 million in non-federal share. We haven't factored that cost or other potential tech bill changes into the budget request yet. The discussions on 12 months of coverage for postpartum pregnant women, we're thinking an additional $80 million total in costs in year one, around $18 million in state dollars. Upper payment limit program to pay hospital-based physician services at average commercial rates, and that could be close to $100 million in total spending. It would probably be a blow to independent physician practices and would challenge the feasibility of long-term value-based reimbursement. Legislation proposing to pay dentists at private provider rates. We don't have a fiscal estimate for that yet. You're going to continue to get requests to spend more money, not less, and there may be some good reasons to do that. And sometimes you have to spend more money to save more money in the long term, but there needs to be a lot of in my experience, a lot of the pay more now and save later doesn't necessarily arrive like you thought it would. But yeah, I also think in a lot of the discussions about the impact of COVID, I think that those are conversations, about dealing with a one-time issue. I don't think the state needs to be using, a one-time pandemic to add recurring expenses to the program, over the long term. Additionally, the new spending commitments could come at a time, close to the end of the public health emergency when the state's, non-federal share expenditures will be going back up and demand for services will, be surging. A fifth cost driver is an uncertainty as Congress and the new leadership at CMS. Even in December, the COVID relief bill Congress passed imposed a 3.75% Medicare fee schedule increase for physicians. And since Medicaid physicians and nurse practitioner reimbursement is currently tied to the Medicare physician fee schedule, that increase will be passed on in the Medicaid program too. And I would expect the total cost of that increase to be approximately $16 to $20 million. Changes at the federal level are going to drive up costs. CMS has a good deal of autonomy, and the outgoing administrator, Seema Verma, did make some good efforts to promote sustainability within Medicaid, but a lot of her initiatives were successfully fought off by special interests. Early signals are that the Biden administration won't be overly concerned with deficit spending, and this mindset that federal spending should be unlimited and unquestioned, may be helpful in the near term in preserving a couple of generous directed payment programs, but states are going to feel those burdens eventually. The last potential driver is pent-up demand. If you listen to any investor call for a publicly traded managed care company, their executives are going to be talking about pent-up demand. Now, telehealth utilization is way up, but people aren't utilizing services the way they did prior to the pandemic. The elderly are staying at home longer before seeking care in our nursing facilities, and as we overcome the virus, we are going to see some surges in utilization on that pent-up demand. Now, to what extent utilization will rise is a question mark, and when. Is it state fiscal year 2022, or the spike be in state fiscal year 23 or down the road? Now, I talk a lot about numbers, but the important question for y'all is what's the public getting in return for all the money that's being spent on Medicaid? You've got a limited amount of money, and you have to decide where to put those limited resources. Medicaid offers health coverage, and that's very important, but coverage in and of itself is not the destination for Medicaid. It's better health for the people receiving that coverage. And as I think through where we're trying to go as an agency, the first thing that we had to do is to ensure that we're a functioning state agency that had a commitment to compliance. I think a core responsibility of any public body is to comply with the rules, provide good customer service to a variety of stakeholders, and to be good stewards of public money. On customer service, I am sure there are times we fall short, but the commitment is there. And we refer to the compliance piece as high integrity, because it's not just mindlessly carrying out a directive, but we're trying to do the right thing the right way. And fiscal prudence goes without saying. It's a matter of public trust, but it's also a matter of agency survival. We're not going to squander money on out-of-country trips or other excesses that derail us from more important work. I think sloppy spending practices undermine credibility and the agency's ability to do more. Today, we're working to become a high-functioning agency. And if you look at, I believe it's page 7, there's a division moving forward slide. It gives you are here. And, we're trying to be, get to that, what I sometimes refer to as a high-functioning, silo in the beginning. And, that means improving health outcomes for Medicaid beneficiaries, elevating quality, lowering spending trends in Medicaid, reducing unnecessary beneficiary and provider burdens, and increasing transparency to the public. The work that's being done with the new quality improvement payment programs for hospitals is really encouraging. And we've also heard loud and clear some of the burden issues that providers have raised over the last few months. I fully expect we will see a significant progress in streamlining, credentialing in the next 16 months. And we are going to be very intentional about making it easier for our providers and beneficiaries to navigate what can be a very complex system. Beyond all of that, though, there is a big role that Medicaid can play in statewide improvements. I mean, we want more than just better health outcomes for beneficiaries. We want them to have better life outcomes. I think we serve 384,000 low-income children. They didn't sign up to be low-income children. So how can good preventive care help them, put them, there are a lot of inequalities out there, but access to quality care for those kids should be something that we're striving for, because this is our future workforce, and we want them to become productive members of that workforce, and we want them to not become to continue to be part of the cycle. Now, for certain beneficiaries, they are going to be on Medicaid. They could be on Medicaid for their entire life, and we need to come up with programs and ensure that they get the best health care that they can get while they're on the program, and for the elderly that they're treated, they're getting good quality care and also being treated with dignity. But there's something larger in play here, and it's trying to make us a stronger state, and bolster labor participation down the road. And look, we're not going. The Division of Medicaid is not going to move into roles that are for community-based organizations that the Department of Health carries out, or core functions of the Department of Human Services. But it doesn't mean Medicaid and those other organizations can't work collaboratively together to set up ways to overcome artificial barriers and bureaucracy and better reach the people that we're jointly serving. And being a real contributor at that top level of the pyramid requires a level of collaboration and sophistication that Medicaid hasn't had in the past. The various health and human services agencies are going to need to work together with data and look at integrating systems and processes. Public payers and private payers are going to have conversations and evaluate health outcomes in a way that hasn't been done before. And for a program that costs $6 billion and may soon cost $7 billion, we need to make sure we're spending money in a way that helps improve the health of Medicaid beneficiaries and also the health of Mississippi. At the end of the day, the legislature sets the agenda, and our agency's function is ultimately executing the laws that you pass and governor signs. But I did want to give you a little bit of the framework that we're operating under and where we're trying to go. I would make a couple of points about workforce. I did for salary and fringe benefits. The legislative budget recommendation was 7.7% lower than actual state FY20 spend in that area. I'm not opposed to trying to accommodate that type of reduction. But if you want the division to decrease salaries and fringe by 7.7%, then the division needs to have the flexibility to move all employees into non-state service positions. Our number of pins has dropped 13% since mid-2017, but we do need to continue to add employees that have the right capabilities for a modern 21st century Medicaid agency, and also those that can be can develop some of those skill sets. And look, I'll just say this, I think the payment structures of today are set up to reward the work of yesterday. Because a division of Medicaid, retiree gets a 3% cost of living adjustment. The current employee gets paid more if they get a promotion. The state also has very generous leave policies. Is that the kind? Is that necessarily? I don't need people taking more leave. I think, but we do need to. I think there's a little bit of leveling that needs to happen at the salary level, particularly with the IT workforce. We're never going to be. And I don't think government organizations should get paid as much as their private sector counterparts. But if we're going to be sophisticated and we're going to do the level of work, particularly on the system side, we're going to have an IT workforce that gets paid closer to market level. I think where we're going today is we're fortunate that we have certain employees that are closing in on retirement. They're going to stay, but we also have a lot of independent contractors, and they tend to be expensive. And I think some of the differences with attorneys, it's a little easier. They're interested in public sector work. With IT, it's a little bit less so. And I think what we're doing as a Medicaid agency, and a lot of these executive agencies, we are doing a lot of operational. It's a lot of systems and technology work, process-driven work, and you probably need to know as much about Lean Six Sigma as you need to know about the Constitution. So, but to say all of that, it's something to keep in mind, going down the road, and particularly as we think about trying to recruit younger employees, and some of those hard to reach skills in data, advanced analytics, and some of the other kinds of areas that are taking a much larger role today. And that's not just because, like, Medicaid, the division thinks it's a good idea. CMS, it puts these requirements on us, and there's some requirements to do some pretty sophisticated interoperability initiatives, and we're going to need to have good people to do that.
Mr. Snyder, let me just briefly, because I'm going to have to turn this over to Senator Wiggins, who's on the subcommittee, to finish this out. I did want to ask you a question before I've got to run, but you mentioned your contact collaboration with other directors of Medicaid, and we can talk about this in more depth, but is there any discussion about the FMAP return back to the old percentages going in line with some reduction in the participants in Medicaid? I mean, I see we have a precipitous increase, steep increase on the enrollees for the last 7 or 8 months, but is FMAP, do you think FMAP changes will be tied to that, or do you think we'll just get a harsh, I know right now it's a cutoff date, that will be independent of the increases or decreases in participation?
There's going to be a big hit the first few months, because we're up at 70. We're not quite sure where the end is going to be, but in that first month, I think you could probably get about 10,000 would probably roll off the first month of the public health emergency, and then it would start to pick up from there. But in this kind of expectation that most states are having an expectation that you're going to see a full 12 to 15 to realize to get back to a pre-COVID world, and even then, I think the numbers are going to be a little higher than what we saw in March of 2020. So yeah, the enrollment is going to drop and eventually kind of catch back up, but it's not going to be immediate.
Well, and we can talk. I mean, obviously we've got another 2 months before we're getting into crunch time, but let's keep the dialogue going on that issue, because I think it's important as we start setting the budget and looking at cost for 2022. With that, I'm going to turn it over to Senator Wiggins to continue the meeting. Okay, thank you.
Thank you, Mr. Chairman.
Covered all of it. So one question I have that maybe is not covered in here, and with the technical bill being open, has a decision been reached or some kind of formula, equitable formula on the MHAP, if I'm thinking of the right one, the distribution, because I continually hear that the distribution of that is inequitable across the hospitals in the state of Mississippi. I keep being told that, oh yeah, it's being worked on, but I keep hearing that it's inequitable, and so where are we on that?
I think we made some good adjustments, and we've moved a lot more money to these kind of quality programs. But yeah, I think as long as the pie is $533 million, people are going to complain about how the pie is split up. And so you're probably hearing, there's probably a viewpoint of, hospitals that have some high costs don't think the model puts enough into, looks at OPRA limits and all of those types of things. Then you have some lower cost hospitals that still probably think those other hospitals, I don't think anybody, I don't think anybody at that individual provider level just loves MHAP, because they would like to get a little bit more. And so what we've tried to do is look at this in a way of like what makes sense for the state, with keeping in mind that, look, we're going to get phone calls about it, and it's going to eat up a lot of time. And I'm not going to sit here and say that we don't, when they model it, we don't look at what if there's a really strange impact to a certain hospital or set of hospitals. Like, that's something that we do consider. It's a delicate balancing act that I'm not sure anybody. I don't know who's going to make everybody happy on that, unless we. Of course, we could just go to purely utilization, and that would make some people really upset, because there's some folks that feel like they're seeing more Medicaid patients, but they're not getting the full their fair allotment for that. And there are others that look at this as more of a where are my costs, and everybody's got fixed costs, and so I guess
if I understand what you're saying on that, and first of all, I appreciate your candor. So when you say a purely utilization model, you're saying to the formula be done in a way to pay out those that have utilization, the highest utilization rates.
That's right.
But the other way of saying that is the current formula is propping up places that aren't having very high utilization rates, and so we're subsidizing through the MHAP program places that, quite honestly, aren't being utilized because, as you said, they're costs. But in the private market, you determine it based on what's being used. So I appreciate your candor on that.
Look, in the private market, we wouldn't have a $533 million supplemental payment program. But the first thing we try to do is make sure that we can get a model out there that CMS is going to approve, because it's always a year-to-year process, and we're at the mercy of CMS to say yes, we want to continue doing this, and it's a generous program. So being able to continue it with that same amount, I think has been is something that we're real pleased we've been able to do. But making everybody happy around that, we haven't gotten there yet, nor do I think we ever will.
Well, disappointing.
I
understand, it's a difficult
honesty,
issue.
though, and look, if, critical access hospitals, some of the small rurals, I think they're winners in the, in
the current formula.
Yeah, and, okay, maybe there's some public policy reasons, for that. I think we're getting more and more, I think that ultimately, though, the losers in this are going to be the people who are not small rurals, whose Medicaid utilization is dropping. So if you're offloading a service line that provided a lot of high dollar services to Medicaid members, the future of your MHAP your MHAP money's not gonna may not look as good. And I think I think you're gonna get a new set of complaints, honestly, because CMS has said, we're not doing pass-through payments, we have to go to quality, and these types, we've gotta tie it to outcomes and value and efficiency and those types of things. Well, in these readmission programs, these other things that we put in, and some of the hospitals that don't have, good numbers, their money's going to get moved to the hospitals that do, and there are going to be some complaints about that too on the methodology, and so look, I know it's not what you want to hear, but it's where we are today.
Okay. And then last, I just want to say a comment. I commend you and your team, as you said, for the third consecutive session year without a deficit request. I think it cannot go unnoticed where we are now versus where we were 4 or 5 years ago. And that's a credit, I will say, to the legislature, the governor's office, and to y'all's office to getting us to, quite honestly, based on comments or no comments I receive, a drop in service to that. Right. So thank you for that from an appropriation standpoint. Okay, with that, anybody, Senator Delano.
First of all, Director, I'd like to echo what Senator Wiggins had said. Thank you for your work. You've done a lot of really good work there. You also spoke about your collaborations with your other community partners, community health partners, one of which I believe is the community mental health systems that we have around our state. I've had the opportunity to speak with Andrew Day in your office. We've talked about some different ways that we can collaborate. You also touched on some IT issues, and I believe that as you modernize your programs and you put these things together and you get back to the mental health components of that, please keep in mind that we really need a way of querying or coming up with reports of how well we can look for some efficiencies within the administration of these community mental health centers. And one of the key indicators is going to be on their Medicaid reimbursement rates and what they're doing or what they're applying for. And I know that may not be a direct component that you're watching for your office, but I do believe that we could do a pretty good job of collaborating on the reports that are generated to determine how efficient we're providing these services, and then also to drill down into the individual services that are provided at the community mental health centers, because we know that we have certain programs that we allow people to come into that's a crisis situation, and we see a recidivism that keeps coming back and keeps coming back, but we're not doing anything to help with that acute long-term care or a long-term maintenance side of it. And I feel like that there's probably some assistance that we could help, or that we could provide through Medicaid to keep that revolving door, or at least slow the revolving door for individuals down. So I appreciate your help in that in the future.
Yeah, look, I think, thank you, Senator Delano. I think that's a great observation, and one of the things that, I've touched on a little bit, but we would like to use some of this Medicaid money that's related to, these IT purchases and that kind of, are there ways legally that we can, help other agents, because we want to connect. And right now, there's silos everywhere, agency silos, CMHCs, do CMHCs talk to CMHCs, do CMHCs talk to mental health? And we're serving, foster care is a real good example. We're, a lot of agencies serving the same people. There are multiple case managers out there, but the case managers, is there collaboration between them, and where are systems? Can we get to a place? And it's not going to happen in the next 24 months, but can we start to move to, and I think it's a good time, because I think, there's interest in this at the legislative level, as there has to be. And I think agency leadership gets along, pretty well with each other, and are on the same page with a lot of those things, and know that they want to know. They want to know. Wendy Bailey wants to know that type of information, and Andrew Sanders wants to know that type of information, and Dr. Wright and Chris Howard, whoever. And how do we link that all together? But not just on the agency side, but on those frontline providers too. And if we can put money in, that they can use for, is to help them learn more about their populations. Now, I say this, and if somebody wants to come with a 12, like we don't have unlimited ability to do all this, and I think we're still pretty early on in the talking about it, but we need to, like, if you talk about it enough, you can start moving forward a little bit, and I think that's something that needs to get done.
Okay, any other questions? One last question. And I know all this, thank you. Can you tell us where y'all are on the risk corridor and as related to COVID-19? Do you know what I'm asking?
Yeah, so we did a retrospective risk corridor, or the managed care plans, for the fourth quarter of state fiscal year 2020. And basically, with those, we set the actuaries set those rates. About 88% supposed to be for Medicaid medical expenditures. So with that risk corridor, we looked at it and said, if it dipped below 87 in that quarter, the managed care plans would return that money to the state.
So I guess I'm getting at, is there going to be an increase in expenditures because of that for FY22?
No, I think we're going to get some money back from the plans for state FY20, and the risk corridor that's in place for state FY21. I would be shocked if it wasn't something that the state ultimately ended up getting a little bit of money back on. The plans are in a situation, a few years ago, their enrollment was declining, but they were, the acuity of the members were going up, and now their enrollment's going up, but the overall acuity may be going down a little bit. So, I think the risk corridors help guard against some of this unpredictability. There's still some things that CMS has to bless. I haven't checked with the staff to see, where they are in some of those approval processes, but I don't see, to the extent that there may be some mention of risk corridor on those cost factors. I think that has more to do with the risk corridor, the money returned from the risk corridor is going to be lower than that, money that we got from the state FY, that we're going to get from the state FY20 risk corridor.
Okay, thank you. Any other questions? All right.
Rise and report.
Motion's rise and report. All in favor, say aye. Aye. Thank y'all very much. Oh. Rehab is still. Are they here? Are they here? I apologize. This was rehab. We have rehab presentation. So I will deny the motion to rise and report.
Mr. Chairman, I withdraw my motion.
Thank you very much, Senator Delano. I apologize profusely. You didn't. It's all good. Sorry about that. So, well, I'll remind Chairman Blackwell. You may proceed. Oh, Senator Butler, we need to hear Rehab, and then, sorry. Any questions? I just want to clarify, so, the increase, for the Section 110 and also for the HCBW program, you're asking for that state increase so that we can draw down the expected federal increases, is that right? Okay. Were those factored into the LBR, or is this since LBR? Okay. You answered my question. You answered my question. Okay. And so then on the TBI waiver, same thing, because we have to do a 50% state match. Okay, and then let me ask you this on the waiting list slots. So you've requested for 150 new ones. My assumption, I think I asked you this, there's an attrition, is that hard 150, or are we talking, is an attrition rate built in that? Meaning, okay, you have 150 on the waiting list, but in reality, what happens is there'll be 75. No, I'm, okay. Okay. Okay, all right. Okay, thank you. Any question? Yep.